Hello students. So today we will talk about basics of venous air embolism. First I will tell you about what is gas embolism or air embolism. Okay. So what is gas embolism? When the embolus is of any gas which is present in the vasculature. For example, it may be nitrogen, it may be nitrous oxide, it may be CO2 or it may be air which is present in the circulation and occlude the flow of the blood, whether in the venous system or in the arterial system. It is called gas embolism. Okay, so when the air is present in the circulation as a embolus and it embolize in the circulation, then it is called air embolism. So air embolism, it is of three types. First is venous air embolism, when the air is present as a embolus in the venous circulation. Arterial, when the air is present as a bubble, as a embolus in the arterial circulation and impeding its flow. And third is paradoxical air embolism. What is paradoxical air embolism? When the person is having patent PFO, patent foramen ovale, that means there is a hole in the interatrial septum. There is a connection between the two atria, right and left. So the blood which is normally goes from the right atrium to the right ventricle, it will go from the right atrium to the left atrium. So the venous circulation is now connected to the systemic circulation. That means the venous blood is now mixed with the arterial blood. Then it will go to the cerebral circulation and the systemic circulation. Then it is called paradoxical air embolism. Okay, what is the reason behind gas embolism or venous air embolism? So the reason is pressure gradient. Pressure gradient, which is act as a driving force that sucks the air inside the venous circulation. So what happened is we already know that veins are low pressure system. So when there is pressure gradient between the atmosphere and the open venous sinuses and the surgical site is above the level of right heart, then it will cause entrainment of the air. It will act as a suction. So it will suck the air inside the venous sinuses because of the negative pressure, and that air which comes into the venous circulation will act as a embolus and it embolize into the circulation. Then it is called venous air embolism. Now, it may be seen some surgeries or it may be seen some diagnostic procedures. What are the surgery where we can see venous air embolism? The venous air embolism mainly seen when the surgical site is above the level of heart. That means neurosurgery, eye, ENT surgeries, head and neck surgeries, right? In neurosurgery, posterior fossa surgery and in sitting position, it is very common, right? That's why nowadays sitting position is not used, not preferred by the surgeons. But the prone position or the supine position does not guarantee that there may not be venous air embolism. Then the other surgeries are craniosynostosis in pediatric patient, spine fusion surgery, torticollis correction surgery, deep vein stimulation placement surgeries, stereotactic surgeries, right? Then the head and neck surgery like radical neck dissection surgery, cancer surgeries, eye surgery, coronary artery bypass graft surgeries. In orthopedic surgery, it may be seen in the total hip replacement or arthroscopic surgery. Venous air embolism may be seen in open chest trauma, penetrating chest injury, thoracocentesis, GI endoscopic surgery, LSCS where there is exteriorization of the uterus, laparoscopic cholecystectomy, when there are some non-operative procedures also. Non-operative procedure means there may be RA catheterization, the central venous catheter placement, and even during removal, epidural catheter placement when anesthesiologist is using loss of resistance technique by using air, then that may be possible through when IV cannula when air is directly injected to the vein. Then intra-aortic balloon placement, rapid blood collection system. Okay, there are some diagnostic procedures where the venous air embolism can be seen. The CECT chest, lumbar puncture during lumbar puncture, thoracocentesis procedure. right? Then what is the pathophysiology of the venous air embolism? Talking about the pathophysiology, okay, now the air is absorbed or sucked into the venous system. Then it goes ultimately into the right atrium via the superior vena cava or inferior vena cava. Now it is coming to the right atrium, and right atrium, through right atrium, it flows into the right ventricle. If there may be two conditions, if the embolus is small or if the embolus is large in size, right? So if the small bubble is there, then it will pass through the pulmonary artery without blocking it, and then goes into the pulmonary capillary, which are the small bore, small diameter capillaries, right? So there may be chances that may block the pulmonary capillary, right? So there is pulmonary capillary obstructions, and this pulmonary capillary obstruction, it will cause systemic inflammatory response. Why the systemic inflammatory response in the seen in the venous air embolism? Because it obstructs the pulmonary capillaries, right? It obstructs the pulmonary capillaries, and because of the obstruction, there is turbulence of the blood flow. Because of this turbulent blood flow, there will be chances of, and the bubble is present, so air bubble and turbulent blood flow, it cause injury to the endothelial cells, and that will release endothelin 1 factor, and this endothelin 1 factor is primarily a vasoconstrictor. So there is pulmonary vasoconstrictions, pulmonary capillary vasoconstrictions also, and the release of the other mediators also. So because the release of the inflammatory mediator, it will cause, because there is injured endothelial cells, so they will induce the systemic inflammatory response, and because this systemic inflammatory response, there is leaking capillaries, endothelial wall, and there is pulmonary edema or bronchoconstriction will be seen. Also, because of the turbulent blood flow, there is platelet. It will induce the platelet aggregation, and it will cause clot formation along the sides of the air bubble also. So there may be coagulopathy can be seen, or hypothrombocytopenia can be seen, right? And if the bubble, on the contrary, if the bubble size is large, then it will cause pulmonary artery obstruction. What is pulmonary artery? It is the vessel which cause blood to flow from the right ventricle to the lung. So there is right ventricular outflow obstruction. So there it will cause right ventricular pressure to build up, and it will cause right ventricle strain. So there is ECG changes also. What changes are seen? ECG in ST or T wave changes, which is commonly seen on the ECG when there is obstruction to right ventricular outflow tract, right? And the right ventricular pressure is raised, and right ventricular heart failure, which cause rise in central venous pressure, right? So these right ventricular strain, it will cause arrhythmia, reduction in cardiac output, hypotension, and the patient will end up into the shock also. Initial, because of the hypotension, there is tachycardia will be seen, and then there is bradycardia, bradyarrhythmia or tachyarrhythmia, and then ultimately patient will end up into the cardiac arrest. And what is one more important thing, if the patient is having patent foramen ovale, means interatrial connection, then what will happen? The blood will go from the right atrium to the left atrium. There is mixing of blood. So left atrium, from there, from left atrium to left ventricle, and it will cause coronary obstruction, coronary blood flow to obstruct, and that will cause coronary perfusion reduction. There is chances of MI or left-sided heart failure or even death, right? And because from the arterial circulation, it may goes to the cerebral circulation. So there is cerebral perfusion reduction, stroke, chances of stroke, cerebral edema. And if the patient in venous air embolism, there are three type of system which are primarily involved, right? First is CNS, second is RS, and third is heart. Three system, right? So in CNS, if patient is awake, there may be focal neurological deficit, there may be confusion, there may be seizures. Okay, so neurological deficit will be seen. Okay, if the patient is awake, then okay, then what happens? Right. What happens with the lung? In lung condition, there is, because of the pulmonary capillary obstruction, there is systemic inflammatory responses there. So there may be chances of pulmonary edema, bronchoconstriction, right? And there is increased dead space, alveolar dead space, because there is no perfusion, only ventilation. So ventilation perfusion mismatch will be seen. There is increased dead space, hypoxia, CO2 will be rise, hypercarbia, and okay, and when there is pulmonary capillary obstruction, then the blood which coming from the left vent, which coming from the lungs to the your left atrium, then this blood return to the left atrium will be reduced, and there may be continuous coughing. If the patient is awake, it will show continuous coughing, tachypnea, dyspnea, reduction in SpO2, peripheral oxygen saturation, chest pain. And what signs we can see? There may be wheezes, rales, crepitation, and the patient will feel a sense of impending doom. So these are basically the sign and symptoms of three main symptoms: CNS, the RS, and the cardiovascular, where ECG changes will be seen, hypotension, tachycardia, then tachyarrhythmias are seen. Okay, under general anesthesia, what we will find? There is rise in ET and 2, means end tidal nitrogen will be rise. There is reduction in end tidal CO2. The SaO2 in ABG is reduced, PO2 is reduced, and PaCO2 will rise. There is, on monitor we can see hypotension and tachycardia. Later on there may be superimposed arrhythmia and cardiac arrest, and then shock, and we have to start CPCR. So this is all about the basics of venous air embolism, and in next class we will talk about the monitoring, diagnostic monitoring tools, and also the treatment part. So thank you.